All right, so my name is Andrew Waters. I'm one of the cardiologists over at Advent Health Shawnee Mission, and my presentation today is on the clinical application of strain echocardiography. Do I have? There we go. So the first question that is often asked is, what exactly is strain imaging? Strain in general is not something that is unique to echocardiography, and it's certainly not unique to hearts in general. It's a mechanical thing, and it's simply the deformation of any object resulting from applied force. When it comes to strain in the heart and as measured in echocardiography, it is the deformation of the heart, and this is measured by the echo machines via specialized computerized software. The 2D images that are generated by echo have unique echo speckles, and the software is able to track the motion of the speckles over time and apply a mathematical formula to calculate the degree of strain. Strain can be measured along multiple axes, including longitudinal, radial, and circumferential. Now, most of the data in regards to strain imaging is related to longitudinal strain, but it's theoretically possible that sometime in the future, there might be some clinical applications to some of the other strain measurements. So one thing that's important to consider when it comes to strain echo imaging is that we take some certain considerations into account. The first is that there needs to be software standardization across all echo machines within the same system. And the reason for that is that, unfortunately, the way that the different companies calculate strain can result in different software packages coming up with different measurements using the exact same high quality two-dimensional image. And of course, when we are making clinical decisions, it's important that we do an apples to apples comparison. So whenever we're comparing prior strain echocardiographic images to the current ones, it's important that they are using the same software package. The second thing that's important to consider is that we need to only make strain measurements with images of the highest quality. The ACC put out a specific statement in regards to this that says that when regional tracking is suboptimal in more than 2 myocardial segments in a single view, the calculation of global longitudinal strain should be avoided. And of course, as with any kind of cardiac imaging, it's important that there is experience amongst the readers. It's important that we are able to make the appropriate recommendations once we are comparing strain echocardiograms. And it's also important that we are able to recognize when, for example, strain imaging is done on suboptimal images and therefore should be disregarded altogether. In regards to the clinical applications of strain imaging, there's a lot of utility in it. Strain has been useful in helping diagnose certain cardiac conditions, and notably some of them include cardiac amyloidosis and hypertrophic cardiomyopathy. Strain also has a lot of utility when it comes to cancer therapeutics and valvular heart disease and heart failure in terms of being able to prognosticate long-term outcomes, which in turn can affect some of the clinical management that we do in these conditions. And also in regards to cancer therapeutic related cardiac dysfunction, there is a benefit of strain in helping prevent disease and cardiac dysfunction from happening using the strain measurements. So when it comes to diagnosis, it's important that we develop the ability to recognize some basic patterns. And the patterns are best seen in what is referred to as the global longitudinal strain bullseye plot that basically takes all the myocardial segments, and we're looking at the ventricle head on. And we can see sort of some of the strain patterns that develop in various disease conditions. So the bullseye plot that I have here on the right side of the current slide represents a completely normal heart in a young individual. All myocardial segments are moving excellently. You guys can see pretty dynamic strain ranging anywhere from minus 18 all the way to minus 29 in some of those apical segments, or minus 31 in some of those apical segments. So this is a very normal bullseye plot with normal strain values throughout. So one of the things that we can use global longitudinal strain is to help differentiate an athletic heart from hypertensive heart disease. So on the left, you've got an athlete's heart. And one of the things that you can see is that by and large, the athlete's heart still has a very normal looking strain pattern throughout. And on the right, you have someone who has early forms of hypertensive heart disease. And you can start to see that the global longitudinal strain, it starts to be affected. And you can see it particularly significantly so in some of those basal and mid segments. These two patients have approximately the same amount of actual hypertrophy on two-dimensional images. And so we can use the global longitudinal strain to sort of help differentiate when you are dealing with an athletic heart versus someone who has early hypertensive heart disease. Of course, hypertensive heart disease is a progressive disease, and we often see progression not only in the degree of hypertrophy and also in diastolic function parameters, but you can also start to see how strain is affected as hypertensive heart disease progresses. And so these two slides are slides from two patients with progressive hypertensive heart disease, and you can see how abnormal they start to look. When it comes to hypertrophic cardiomyopathy, this is a disease that has a lot of heterogeneous phenotypes. And depending on the morphology of the hypertrophic cardiomyopathy, you can also appreciate how this affects strain. The first one is someone who has the concentric form of hypertrophic cardiomyopathy, where all myocardial segments are severely thickened. And as a result, you can see sort of a global loss of longitudinal strain throughout the entire heart. The second one has the apical form of hypertrophic cardiomyopathy. And here you can see that you have preservation of strain throughout most of the myocardium, except in the severely hypertrophied apex. And there you see a pretty drastic decrease in strain altogether. And the last one is a patient that has the basal septal form of hypertrophic cardiomyopathy. And you can see that particularly the basal septal segments are the ones that are most affected. Of course, just as with hypertensive heart disease, hypertrophic cardiomyopathy is a progressive disease. And so you can see the change in these bullseye plots over time as the disease progresses. Eventually, many of these end up reaching the burned out phase, in which you kind of see a strain pattern that looks very similar to the first bullseye plot that's on the left here. When it comes to cardiac amyloidosis, strain is also a good way of, has a lot of utility as well. These are two somewhat typical bullseye plots that you see with this particular disease condition, where you see what is often referred to as the cherry on top pattern. You see a general loss of strain throughout most of the myocardium, but with preservation of the apex. Cardiac amyloidosis is a disease that is kind of becoming more and more at the forefront now, especially because we now have some treatment modalities for this disease, and in the recent past we didn't. Where strain has a lot of utility is the fact that compared to some of the other imaging modalities that we use to evaluate and diagnose cardiac amyloidosis, such as technetium pyrophosphate scanning or cardiac MRI, echo and echo with strain imaging still has that general utility of the fact that it is much cheaper than other imaging modalities, and it's easier to obtain compared to other imaging modalities. So you can use it as a screening tool in patient populations that are higher risk for having this condition, such as, for example, patients that are getting transcatheter aortic valve replacements, or patients, for example, that have received bilateral carpal tunnel releases, because these are populations in which you see cardiac amyloidosis at higher rates compared to the baseline population. So the echo can become a much easier screening utility tool in those conditions. When it comes to prognosis, strain imaging has found to have a lot of really good prognostic value. I deal with a lot of heart failure patients, and so certainly there's a lot of utility of strain imaging in the heart failure population. Global longitudinal strain has been found to be an independent predictor of mortality. And this is true even when you factor in a number of other variables and to see if there's any covariation between these different variables, including as to whether or not someone with heart failure with reduced ejection fraction has an ischemic or a non-ischemic cardiomyopathy. In patients who have mid-range or preserved left ventricular ejection fraction, global longitudinal strain has been found to be a greater degree, has been found to be more predictive of worse long-term outcomes compared to just the ejection fraction by itself. And in patients that had ischemic cardiomyopathy, global longitudinal strain was found to be an independent predictor of mortality, regardless of whether or not patients received percutaneous or surgical revascularization. There's even data for some atypical forms of heart failure, such as hypertrophic cardiomyopathy, where abnormal global longitudinal strain patterns were also predictive of worse long-term outcomes. In the acute heart failure population, both immediately after a myocardial infarction, but also in a general heart failure population, global longitudinal strain was also found to be strongly predictive of worse outcomes. And the reason this is important is that by being able to identify in the patients that are more likely to have worse long-term outcomes, we're able to tailor our therapies in terms of how aggressive we do our post-hospitalization follow-ups, perhaps how aggressive we're going to be with some of our medications, with ultimately the goal of trying to reduce the heart failure hospitalizations long-term. And so that is why I think having these prognostic values can be of great utility in a clinical setting. As far as prognosis, global longitudinal strain has also been found to be strongly prognostic of valve disease as well. In a general aortic valve stenosis population, patients who had abnormal mechanical dispersion plots or abnormal global longitudinal strain patterns were found to have worse outcomes when they developed significant aortic valve stenosis. Mechanical dispersion is basically the timing between the contractility of the various segments relative to the electrical the presence of the electrical QRS on the EKG. And in a more normal heart, you see the mechanical dispersion pattern that you see in the bottom picture, where everything kind of lines up normally. But when you start to have abnormal mechanical dispersion in various segments, where the different segments aren't contracting simultaneously relative to their electrical signal, then you end up with worse long-term outcomes. When patients ultimately end up undergoing valve disease, there's data that suggests that following aortic valve replacement and mitral valve replacement, global longitudinal strain is strongly predictive of worse long-term outcomes as well. And in the post-TAVR population, I also was able to identify an article that talked about how patients with the low flow, low gradient, severe aortic valve stenosis, when you have improvement early on in global longitudinal strain following TAVR, those patients tend to have a better long-term outcome. And so these are various ways in which strain imaging can help prognosticate patients with significant underlying valve disease. Now, this is the area where probably strain has the greatest utility, so I kind of saved it for last. And that is in the area of cancer therapeutic-related cardiac dysfunction, or what is often just referred to as cardio-oncology. This is a relatively growing area in the field of cardiology. This is a list of all, this isn't even a list of all the metabolites or all the chemotherapy agents that are cardiotoxic, but this is part of a growing list. So this is not even supposed to be the list of everything, but as you guys can see, we are finding more and more cancer medications that are cardiotoxic, and global longitudinal strain is useful in helping to identify early signs of cardiac toxicity so that we can treat these patients better. Now, most of the data when it comes to strain imaging comes from some of the older medications that we've known for a while are cardiotoxic, specifically anthracyclines and the monoclonal antibodies for HER2/neu, such as trastuzumab, which is the trade name for that is Herceptin. Global longitudinal strain can predict early cardiac dysfunction and can also be used to guide cardioprotective therapy. In fact, when you use global longitudinal strain to initiate cardioprotective therapy earlier, you have less cases of cardiac dysfunction later on compared to when you're just relying on ejection fraction. As far as other agents, we are now learning also that immune checkpoint inhibitors are associated with myocarditis, and global longitudinal strain can predict early myocarditis before the disease can become more fulminant. And this is another way, another line of agents that strain has been found to be useful with. Now, strain imaging can be followed sequentially, and this is what how we monitor for chemotherapy-induced cardiotoxicity. And the moment we are able to identify that that these chemotherapy agents are starting to produce cardiotoxic effects, we can then tailor therapy. And that can be either in the form of initiating cardioprotective therapy with evidence-based beta blockers and ACE inhibitors, but it also potentially allows us to communicate with a medical oncology team and discuss about the possibility of either switching to a different agent or perhaps switching the dosages of the existing agent. And of course, this has to be done as a team effort because as a team, we have to discuss sort of the risks and benefits of switching perhaps to a second-line agent or reducing the dose of the first-line agent in regards to the patient's long-term oncologic prognosis. As far as the parameters for diagnosing cardiotoxicity, there was an expert consensus statement that kind of divided them into definite and probable criteria. For the definite, reduction in left ventricular ejection fraction of more than 10 absolute percentage points to an ejection fraction of less than 50% is definite cardiotoxicity, or a decline in left ventricular ejection fraction of greater than 10 absolute points, but to an EF of greater than 50%, but accompanied with a global longitudinal strain that is less negative than minus 17%. As far as probable global longitudinal strain, a decline in left ventricular ejection fraction of less than 10 absolute percentage points to an ejection fraction of less than 50%, or a global longitudinal strain of greater than 15 relative percentage points from baseline. Now, this is one of those things where I wish they kind of phrased it a little bit better, but you have to recognize that this is a percentage of a percentage. So for example, if someone starts out with a global longitudinal strain of minus 22%, and then the follow-up echocardiogram shows a global longitudinal strain of minus 18%, then this is an 18% relative change. The calculation is the 22 minus 18 over 22. It's not an absolute percentage change of 22 minus 15. It's a percentage of a percentage. As far as our monitoring protocol, this is kind of how we do it within our cardio-oncology program. Anytime someone is receiving an agent that is known to cause cardiotoxicity, they obtain a baseline transthoracic echocardiogram with strain imaging. Any baseline abnormalities results in an immediate cardio-oncology consultation to discuss what are the next steps. By default, we obtain transthoracic echocardiograms with strain imaging every 3 months. And so long as things stay normal, we just continue to monitor. We do targeted cardio-oncology surveillance for abnormal follow-up echocardiograms, and that kind of depends on the agent and the kind of abnormality that we see. We do defer to the cardio-oncologist as far as how often we are going to do any follow-ups for any abnormal echoes, as well as when to initiate chemoprotective therapy. We do this as a team approach, again, with the medical oncology team as well. At the completion of chemotherapy, we always do a default completion echocardiogram. And then we also do targeted post-chemotherapy surveillance. The post-chemotherapy surveillance is mostly done with the anthracyclines because that particular chemotherapy agent, in particular doxorubicin, has been known to cause cardiotoxicity sometimes years after completion of the last cycle of chemotherapy. It's a rather insidious drug that way. And here are my citations. So that way, if everyone wants to look at some of these articles that I was able to find, feel free to check them out.